Hi, I'm Lisa Davis. You're listening to It's Your Health. If you have a man in your life, you are going to want to hear this. It is such an important thing to think about your man's health. And if you are a man, I really hope that you take this to heart. I have got the wonderful Dr. Deepak Kapoor on the program, and we're going to be talking all about prostate cancer, things that you need to know. Dr. Kapoor is the president of Advanced Urology Centers of New York, the largest independent provider of urology services in the United States. Dr. Kapoor, welcome to It's Your Health.
And thank you very much for having me on to share some of this information with your listeners.
Yeah, it is so important. You know, my father-in-law had prostate cancer, and he's doing fine now, but he still has to get his numbers checked. And it seems to be very common after a certain age. Talk to us about who's at risk, how common it is, and things along those lines.
Well, thank you. I think it's very important to understand that prostate cancer is the most common solid tumor in adult men, with 1 out of every 7 men at some point in time in their lives being diagnosed with prostate cancer. What's really important to understand, however, is unlike what some of the recent publicity has been, prostate cancer is a very serious disease. Now, it's true that in older men, the disease can be indolent and slow growing, but prostate cancer remains the second leading cause of cancer death in the United States in men. In fact, about 1 man every 30 minutes will die of prostate cancer. Nearly as many men die of prostate cancer in the United States as women die of breast cancer. And nobody considers breast cancer to be a minor health problem. It's a very serious problem in women, and men need to understand that prostate cancer is a very serious health risk. Now, the issue that we have with prostate cancer is, as we said, in some men, prostate cancer can be an indolent and slow-growing disease. The problem is that in advance, it's very difficult to tell which are the patients that are going to have slow-growing disease and which are the ones that are going to have more rapid disease. And the only way that we can find that out is to first identify the disease. So the second aspect of what you asked is who's at risk for prostate cancer. Well, the short answer is pretty much every man is at risk for prostate cancer, but there are definitely subgroups of men that are at greater risk. And those subgroups of men are people with a family history of prostate cancer, and that is like a first-degree male relative, a brother, a father, uncle, something like that. On the paternal side, the risk doesn't seem to carry from the mother's side. African American men have a very significantly increased risk of developing prostate cancer, and there does seem to be some evidence that men that have been exposed to Agent Orange may have an increased risk of prostate cancer as well. So if you fall into one of those risk categories, certainly you should be quite a bit more vigilant than the population in general, who also needs to be careful about this disease as well.
So is it at at 50 you should get your prostate exam, or at age 40 if you have a risk factor? Give us those parameters.
Well, that's an interesting point, Rachel, and I'm glad that you asked, because there's a lot of confusion, particularly around PSA testing. And if you don't mind, I'm going to address some of the controversies that exist with prostate cancer therapy. And the United States Preventative Service Task Force, or the USPSTF, a few years ago issued a rating that suggested that nobody should get a PSA test done, that PSA screening for prostate cancer was ineffective. And this led to a lot of confusion among men and among certain primary care practitioners. It's important to understand that essentially every major urological organization in the world has taken issue with the USPSTF recommendation because it's not a nuanced approach. You know, it's a one-size-fits-all approach that really didn't look at all the literature appropriately. And I'm sad to say that on this particular issue, the USPSTF simply got it wrong. You know, we know that the early detection of prostate cancer saves lives. If you just take a look at the epidemiological data, prior to the advent of PSA testing for prostate cancer, the 10-year survival for prostate cancer was less than 50%. Now the 10-year survival for prostate cancer is 99+%, which is utterly remarkable. When we take a look at where we were in the past, many men, a significant percentage of men, presented with disease that had already spread outside the prostate when it's no longer curable. Now that number has really shrank. So what we've now adopted is a very nuanced approach to prostate cancer. We understand that those men at higher risk should be looked at and scrutinized a little bit more closely than the general population. But the prevailing recommendation that was adopted by the international community of oncologic experts that treat prostate cancer is that every man should get a baseline PSA sometime in their 40s. Now, based on the result of that PSA, will determine the interval by which follow-up should be. So if your baseline PSA is very, very low, data indicates that your lifetime risk of prostate cancer may be significantly lower. Whereas if your baseline PSA is above a certain threshold, your risk is higher and you should be followed more often. So when we weigh together your relative risk factors along with your baseline PSA, so, for example, you may get a baseline PSA at age 42, and based on the results and your risk factor, your doctor may tell you you don't need to get another check until you're 50. By the same token, they may say, okay, you know what, you should be checked every year or every other year. So it's a very nuanced approach that we're now taking to prostate cancer screening, and the best recommendation is for every individual to talk to their own healthcare provider to determine what their relative risk is and to create a custom strategy for PSA evaluation. You know, this is not a cookbook. It is not a one-size-fits-all type of approach. We take all the various factors together and we create a custom strategy for each patient so that we minimize the risk of detecting a